Nós teremos agora a apresentação do Guia de Inovação Aberto pela Nesta e eu chamo a senhora Madelene Gabriel.
I'm Madelene Gabriel, I'm from Nesta in the UK, and I'm afraid I have to give my presentation in English because despite the high level of success that we've heard about today, I'm afraid I had a personal failure. It was my ambition to learn Portuguese by the end of this project, and I'm afraid I just haven't quite managed that. But I hope you can understand. So along with my colleague Isaac Stanley, we're going to tell you a little bit about the guide to open innovation in health that we've produced as an output of this project and with cooperation and participation of our partners here in São Paulo. And I want to start just by while the slides come up, by saying thank you and what a privilege it is to have been part of this project. It's been a really fantastic opportunity for us to learn so much about Brazil, about São Paulo and the work you're doing here. And I think the outputs are going to be really high impact. Before I start telling you a little bit about the guide, I'll tell you... How are we doing? Oh, it worked earlier. Right. I'll just tell you a little bit about who we are, just for those of you who don't know us, which I expect will be a few. So we're a charitable foundation based in the UK, an independent not-for-profit foundation. Our mission is to support innovation for public benefit, and we do that in a variety of ways. So we support innovators directly through grants and non-financial support. We have an impact investment team that makes loans and equity investment in innovations that have social and environmental outcomes. We do research and analysis looking at innovation systems and ways to support innovators, and that work is global in its scope, and that's what Isaac and I work on. And we also have an innovation skills team whose role is to build capacity of people managing and participating in innovation, mainly in governments, multilaterals, bilateral agencies, and NGOs around the world. So that's us. I wanted to start talking about the guide by telling you something I'm sure you already know. Good ideas can come from anywhere. I don't know if any of you will recognise this gentleman. He's an English man. He's called Tal Goldsworthy. And he suffers from a genetic condition called Marfan syndrome. Marfan syndrome it affects the production of a particular protein, which has the result in making, for example, it makes you very tall. It makes your bones long and slender. I think Tal is 6'5" tall. It affects the structure of blood vessels. So Marfan syndrome sufferers often have to have heart surgery during their 30s or 40s because the aorta that goes into the heart becomes weak and can result in aneurysm, internal bleeding. So Tal Goldsworthy, he's not a physician, he's an engineer by trade, and he was told by his doctor that he was likely to have cardiothoracic surgery. The traditional procedure involves taking out the aorta and replacing it with a plastic tube, and also taking out some of the valves in the heart and replacing them with mechanical valves. That process can be very successful, but it also, because the valves are mechanical, there's a risk of blood clots forming. So sufferers who've had this operation have to spend the rest of their life taking anticoagulant drugs. And Tal, as an engineer, thought, well, there must be some sort of better way. And he looked back to his engineering background, and he thought, well, as an engineer, if pipes don't work, we don't necessarily just replace them. Sometimes we strengthen them. And he came up with an idea. It's called external aortic, I'm going to have to read this, external aortic root support. So it supports the root of the aorta, so ERAS. And basically he uses a CT scan to then create a 3D printed model of an individual's heart. And then from that, he can make a textile support which a surgeon can insert around the aorta, and it fuses with it over time, and essentially removes the need to take out parts of a patient's heart. So I think this is a great example of how open innovation can be really valuable. Tal is someone who is outside the medical establishment, and to get this innovation into the system, he had to form relationships with surgeons. He met a particular professor at a university in London, UCL, who was able to open doors for him in the establishment. He eventually was introduced to a cardiothoracic surgeon at another London hospital who agreed to do the first ever procedure. Tal had always wanted to be the first patient, but in the end he agreed with this doctor, John Pepper, that he would observe the first operation. However, in the end, the patient who was going to be operated on pulled out, so Tal, in fact, was the first patient. And it seems to have been very successful so far. He set up a company to develop this technology. The numbers of people receiving this operation are still quite small, around 20 a year around the world. But as attitudes and amongst surgeons changed and awareness of this procedure is raised, he hopes that this will eventually become the preferred procedure. So I think that good ideas can come from anywhere, including people who are not in the medical establishment or the health research establishment, is one of the reasons why we think open innovation is really important. And this idea, health innovation systems becoming more effective when they're more open, is really the hypothesis that underpins this project and underpins the guide that we've produced. And as Professor Ari said earlier on, open and closed are not binary situations. All health innovation involves some degree of openness. So what we're trying to do here is show how it can be more open. We've heard a lot today about the pilots at IAL and what they mean in practice. We think open innovation in health essentially means new forms of collaboration between different types of actors in the system. Very often, as in the case of the technology push pilot, it involves collaboration between private and public sector organisations. It can also involve new forms of collaboration between the public sector organisations themselves and their employees, so their employees working in different ways, and between public sector organisations and patients or citizens. So really, we see this as creating new collaborations, but also a little bit more than that, perhaps blurring the boundaries between those organisations and asking people within them to take on slightly different roles. So maybe an engineer, a patient becomes a designer, a researcher. Or, as we've heard from the technology push pilot, researchers in public health institutes become a bit more entrepreneurial. And we use the term porosity, which has been mentioned a couple of times by our partners today, to encapsulate that, so that the system becomes more porous. We've heard lots of good reasons why open innovation is important today. We think at a health innovation system level, health innovation systems look different all around the world, but they have some common features and some common challenges. Often innovation processes can be quite inefficient in the sense that they can be slow, so the average time from research to clinical practice, for example, has been documented as being about 17 years. They can be expensive. They can also be a bit wasteful. We heard today about the number of technologies at IAL that had potential for commercialization, 98 technologies. If you hadn't have done a pilot like this, some of those might never have seen the light of day. There's a huge amount of potential that can otherwise be wasted. And also the innovations they produce are sometimes poorly targeted or distributed. And we know that there are neglected diseases, for example, where there's not enough innovation happening. Sometimes this is because of gaps in understanding of needs. So technologies that are produced perhaps are not well tailored to the health systems where they'll be used, or not well designed to meet the needs of patients and users. And as the example of Tal Goldsworthy indicates, sometimes traditionally health innovation systems can be very dominated by professionals, or those with professional qualifications, with the implication that those that don't have them aren't able to innovate, and we know that that's not the case. So what we've done is looked at examples of health innovation, open innovation in health initiatives from around the world, and they seem to have three main drivers that somewhat overlap, as we've tried to show in this diagram. So on one hand, they often aim to try and make health innovation processes more efficient, or to make the outcomes of those innovation processes more efficient. Often that is underpinned by gaining a better understanding of needs of those in the system, of patients and users. There's also an impulse to make health innovation more democratic, so more responsive to a wider range of priorities, the priorities of patients and citizens themselves. So the output of this is going to be a guide. We've nearly finished it. We are doing some work with our partners later today and over the next few days to make sure we capture the Sao Paulo experience fully in the report itself. It'll be available online in Portuguese and in English, and we hope to disseminate it quite widely. And what it does is that it tries to show decision makers in health systems how they can support open innovation in health. It does that by providing practical examples from around the world, and it tries to give insights then into how you can, as a decision maker, design an innovation initiative that can support more open innovation in healthcare. I think, I said at the beginning, you'll I'm sure, agree with me that good ideas can come from anywhere, and the idea that more collaboration in innovation is needed is not new. Everyone agrees that. But the challenge is how do you achieve that in practice? And I think that's what this project has been about, and that's what the guide is trying to do. We map 18 different kinds of open innovation initiatives, from accelerators and challenges, as have been discussed today, through to things like improvement collaborations, open data mapping, and so on. There's quite a range of things in the guide. Each one of those types of initiative addresses one or more specific challenges with innovation systems, such as the need to get in a wider variety of voices into the setting of priorities, or the need to help researchers become more entrepreneurial. And we structured the guide with a kind of simplified version of the innovation cycle. So we look at problem identification and how that can become more collaborative, the process of invention or ideation, coming up with new ideas, and then adoption and diffusion in health systems, because actually when talking about health innovation, it's often that final stage that can be most challenging. As I mentioned, we have examples from all around the world, and I think what's really powerful about this document is that we're able to draw on the real practical experience of the partners here in Sao Paulo. So it becomes less theoretical and more grounded in real experience. And I think documenting that in the guide, showing how you here went through the steps you did to identify what challenge in the innovation system you wanted to tackle, and then to design and put into practice a pilot which hopefully will be sustained in the longer term, will really help bring the guide to life and show how this way of working can be beneficial. I'm just going to pass over on to Isaac to talk a little bit more in depth about some of the content in the guide.